Welcome, everyone. It's time to get started, so I guess we'll just go ahead and get started. I'm Katie Morales. I'm an associate professor. Can everybody hear me okay? I can't see the chat box, so if somebody could just confirm you can hear me fine.
We can hear you great.
Perfect. And will somebody monitor the chat for me? So if there's any questions, because I can't see it.
Even people who just own small businesses and don't.
All right, well, I'm going to get started. So I'm Katie Morales. I'm an associate professor of nursing at the University of West Georgia, and I'm our student success coordinator. And I'm also a co-chair of the student engagement committee for SNRS. Trying to advance the slide, it's not going. There we go. And just a friendly reminder of the annual, the 39th annual conference that's coming up February 19th through 21st in Memphis, Tennessee. So you can register now. And our wonderful conference sponsors. I'll give you a moment to look those over. Appreciate all the support from our sponsors. Today, we're going to talk about Spooktacular Research 101, unmasking the basics of academic inquiry. And so I picked two infamous researchers to go with Halloween, Dr. Frankenstein and Dr. Jekyll. So when I teach evidence-based practice or research to graduate or undergraduate students, I often start with this teaching strategy that I created, and it is published on the CUSUM website if you'd like to see it. But I introduce evidence-based practice using internet shopping. So imagine we're going to buy a pair of shoes. The first thing we're going to do is search for shoes, and there are filters on the left side of the page that you can select, just like when you do a literature search. And if you search best running shoe, for example, you'll get a lot of returns. And you'll see that Nike has one, Adidas has one, etc. And you know that if you pick one from Nike, they're not going to tell you Adidas is a better shoe. You know there's bias built in. So you look for an unbiased source such as Consumer Reports. And if we pull up Consumer Reports, which we do in this video, so this is a hyperlink, and I'm hoping you'll have access to the PowerPoint afterwards. You'll be able to click it and watch the video. But we go to Consumer Reports and we look for the best shoe. And when we pick one, if you click it, it takes you right to Amazon, where you can look at this shoe and see how many star ratings it has, and you can see customer comments. So what that tells us, and you also see out of how many reviews. So we have a sample size. We know that if 3,000 people reviewed the shoe, that's much more rigorous than if 3 people reviewed the shoe. And you might be the kind of person that says, I don't really care what the comments say. I just want to know how many stars out of 5 is this shoe. And that means you're more of a quantitative bent. Or you might be the person that says, I really don't care about the stars. I want to read the comments. And you know you're not going to be able to read 3,000 comments. So you read the comments until you kind of develop a theme. And you get the idea that maybe this is a great shoe, but the customer service is terrible. So you start developing themes based on the qualitative data. And there's not a benefit to being one or the other. It's just your personal preference. You might be a mixed method person like myself that looks at the stars and then looks at the comments to see, why was this rated 3 stars out of 5? And that's all fine. So then I always want to discuss the legal and ethical considerations for research. So I just have these series of little videos I make for my students that I call it whatever the concept is. So this would be legal and ethical in 10 minutes or less. So we'll get through it much faster than that. So in a nutshell, I always tell my students, we can't do anything till Simon says, and Simon is IRB. We can do nothing until Simon says. So we have to have IRB approval. And then the next person that we can't do anything till they say is the participant. So we have to get informed consent from our participants. IRB is all about protecting the subjects. And how do we collect our data? Is it going to be anonymous, meaning we can never track it back to who said it? Or is it going to be confidential, meaning we could, but we're not going to disclose that to anybody? And there's pros and cons to both. So I did a midterm survey one semester. It was the fall of 2020 when COVID was still just raging, and there was a lot of stress, just to see how my class was. And I asked on a scale of 1 to 5, how's your mental health? And some students said 1. So now I had a dilemma because I couldn't make sure, did you understand that 1 meant terrible and 5 meant wonderful, because it was anonymous. So then I had to decide how to deal with this dilemma. So I just reviewed all the resources for the entire class. So there's benefits to anonymous and benefits to confidential. Then we always want to know, how will the participants' data be protected? And that will be spelled out quite well in your IRB application. We always want to look for conflicts of interest and where they disclose. So just looking at our shoe example, if I was on the board for Nike and I was writing this report for Consumer Reports, you would want to know that. And then always follow the money. Is there any funding for the research? So we just want to be transparent about that. Then next in our class, we pick, the students pick a topic and then find a clinical practice guideline to go with that. And I always tell them, think of this EBP, evidence-based, as a present. So an evidence-based present. Somebody else did the heavy lifting, looked at the literature, appraised it, set forth recommendations that are supported. All that work was done for you with clinical practice guidelines. So whenever I review a topic with students, I'm old-fashioned. I like to go back to the who, what, where, why, when, and how. So when we look at clinical practice guidelines, the who would be the panel of experts. So clinical practice guidelines come from a panel of experts. And typically we just describe this in aggregate form, looking for who's missing. So if we're looking at a clinical practice guideline and there are pharmacists and medical doctors and physical therapists, but no nurses, we'd want to address that. That's not a QS and competency. Teamwork and collaboration is definitely the way to go. And again, looking for that conflict of interest in funding. And then some clinical practice guidelines even add another layer of rigor where they'll take their recommendations and post them publicly or send them to an external review for another panel of experts, or post publicly even for, I know one that was written for lupus, post it so that people with lupus could look at it and critique it and offer suggestions. Or what, when we're looking at research, we always have our independent variable, and with clinical practice guidelines, that's going to be the recommendations that they're putting forth. And our dependent variable is always that outcome measure that we're interested in. So if the clinical practice guideline was to prevent postpartum hemorrhage, that would be our dependent variable, and our independent would be whatever interventions, recommendations they're putting forth to help us reduce postpartum hemorrhage. When we think about where for clinical practice guidelines, we want this to be a practice setting. And for us, we want it to be related to nursing. So sometimes students are interested in a topic, but it's very hard to relate it back to nursing. And since nursing is a practice profession, we do want to make sure we stay within our scope of practice and within our setting, and that we represent our profession. With any research, when I think about when, we always have retrospective, which I always say is looking backwards. And there's pros and cons to that. One of the cons, anytime we're looking retrospective, is we have no control over anything. We have the data, but let's just say we're looking at blood pressures. I don't know how they collected it back then. I don't know if they did the left arm, the right arm, if they did not document it, the person was sitting or lying. So retrospective offers some challenges. Concurrent is present. And then prospective is if we're trying to predict into the future. When we think about how for research, most all research is going to start with a review of the literature. And the undergrad students will love to say there were no gaps in the literature, and they're very proud of that. And I have to say, well, then there's no reason to do the research. You're saying we already know everything we need to know about this topic. So it's not a good topic for us to research. So we're always looking for the gap. And I always give this example. If we were to search heart disease in America, and I have a student do it when I say it, you'll pull up you'll get so many returns immediately. But if we look for heart disease among goat herders in Zimbabwe, we get way less return. So that's our gap. We've never looked at this population. So with the CPG, since there is a review at secondary literature by the panel of experts, we want to make sure that their literature review is auditable.
Going way too fast on this road.
Is everybody okay? I'm going to continue if everybody's all right. We want to make sure the literature review is auditable, that we know what search terms they use, what databases they search, what their inclusion criteria and exclusion criteria for the data that they're going to pull into the clinical practice guideline are. And then once they pick the data they're going to include into this clinical practice guideline, we need to know how did they appraise the evidence. And there are a couple of different methods. Two that are pretty popular is grade and agree. And there's Joanna Briggs tools. I don't want to say it almost doesn't matter. What we want to know is that there was some system in place to appraise the evidence, to make sure that whatever they decided to include in this as their evidence was worthy to be included. And then they're going to set forth the recommendations, and they typically will give a grade to that recommendation. So if you've taken advanced cardiac life support, for example, they'll say this drug is a recommended and it's 1, meaning the benefit far outweighs the risk, or it might be a 3, meaning there's really not clear evidence to say the benefit outweighs the risk. So we'll look for the level of recommendation. When we look at why, again, for the clinical practice guideline, it's to address that gap in the literature. Clinical practice guidelines help address how questions, and it promotes evidence-based practice, which I think is an appropriate level for our undergraduate students. I don't think it's appropriate that they do research for the average, not your honor student, but they should be able to consume the research and know how to appraise it. Being that we have been consistently the most trusted profession, people are going to ask us our opinion. When we look at level of evidence, this is the criteria we use for our class, and this is from Low Biondo, Wood and Haber's nursing research book. And you can see clinical practice guidelines are down here at the bottom. They're level 7. And this gives us an opportunity to discuss why is it so low, and it's because it's secondary data. This is not original research. This was at present that somebody else did for us and amassed it. I don't know why my slides are advancing on their own, but so CPGs, clinical practice guidelines in a nutshell, remember they're the opinion of experts. And this gives us an opportunity to review in class that I always say, where's your opinion on this? Right here on this level of evidence, where's your opinion? And it's not there. And don't be offended, mine's not either, right? So in evidence-based practice, we have to cite everything. If you tell me the sky is blue, you better tell me how you know the sky is blue, because our opinion is not on this evidence table. And it is level 7 using this. There are plenty of different ways to grade the evidence. So you might use one from Johns Hopkins, it would be different, but we just want to be consistent. And the reason it is so low is because they're secondary sources. So then we look at qualitative evidence. And so let's look at the basics of qualitative. I always say, when you hear qualitative, you hear that L, think L equals language, our data, our words. And if it had a mascot, it'd be the Care Bears, in my humble opinion, because we're going to explore thoughts and perceptions and feelings. So I always put up the Care Bears to help the students remember qualitative. It's about that lived experience. So remember with research, the population is at global. If we were looking at nursing students, it's all nursing students, but our sample is from our study. And with qualitative, we're going to purposefully, on purpose, pick people who have had that experience, because I want to explore this experience. I need you to have had it to be in my study. The other who we always have in research for qualitative is going to be the interviewers. So remember, with qualitative, the data are words. So how we get those words are through the people that are interviewing our participants. So we still have that independent variable. Here, it's the individual experience, cultural factor, or social.
Did you know Suzette, or that Laura talked to Suzette?
No.
Okay, well, she applied for that patient safety job. So she, when I talked to her about it, I said, well, you could get out from Suzette, but they may not be flexible. And that's kind of what Becky told her. It's Monday through Friday. You can telework 1 day a week, So she decided to go talk to Suzette, asking about, what's the future of this position? Is it always just going to say the PIN nurse, or is there going to
Okay, I think I've muted it. Excuse me, let me get back to our presentation. Okay, can everybody still hear me?
Yep.
I see it.
Good.
Okay, perfect. Okay. So our independent variable is that individual experience, cultural factor, or social context influencing that phenomenon of interest. Our dependent variable is still the outcome measure, but it's a little weird to say measure with qualitative. It's what's being observed or studied to see how it changes in response to that independent variable. So it's the lived experience. How does the lived experience of being a goat herder in Zimbabwe affect heart disease? Heart disease is the dependent. The independent is that individual experience. Where we do qualitative research is in the naturalistic setting. Because we want to know about this phenomenon, we'd like to go where it actually occurs in the environment. We have a couple of different options of obtaining the data. It can be face-to-face. It can be virtual, such as we're doing today. And I hope you can already think about some of the pros and cons to both, right? We're losing a lot of nonverbal. I can't see you while I'm presenting, so I don't know if you look interested or not. So there's a lot of pros and cons to how you collect the data. Or it can even be open-ended surveys where it's written. And there's pros and cons to that too. It gives you a chance to really think about what you're going to say and edit if it's written, versus it's more spontaneous and you get the nonverbal if it's face-to-face. We still have our retrospective look, concurrent and prospective focus that we can select with our research. And how it will start with a review of the literature, but qualitative is very good for things that we don't know a lot about. So the literature review usually is smaller, if I can say, at the beginning of a study with qualitative, because just by nature, we don't know what it's like to be that goat herder in Zimbabwe with heart disease. So the best way to find out is to go talk to that person. And the best way to do that would be to go to Zimbabwe and see what do we see that we might not have even thought of asking about when we're there in the setting. So it's going to be semi-structured interviews because their data are words. We want to give them the opportunity to use as many words as possible. So thinking back to fundamentals of nursing, it's that open-ended question. We want them talking. We want to guide them a little bit, like talk to me about heart disease, but then we just leave it open for them to take us on whatever journey they need to take us on. It can be face-to-face or virtual, as I said, but it can also be individual or focus groups. And I hope you're thinking about what's the benefit of both of those. Individual, sometimes people find the participating in qualitative research is therapeutic in and of itself because somebody is interested in hearing their voice, versus a focus group might be beneficial, but it also might give you some social desirability or maybe hesitancies to speak. So if we wanted to look at women who have come out of sex trafficking, they might not be comfortable speaking about this in front of a lot of other women, or they might find it very therapeutic to talk about it. So you just kind of have to see what your goal is and how it goes. When we think about why, again, we'll look at the purpose of the research. Qualitative is very good for describing that lived experience and answering the why question. And you can look at all the different types of research questions you could have for a qualitative. So when you're reviewing those shoe shopping comments, remember, you could be looking at it from any of these different angles, if you will. You know, I want to get the description, or what was the experience of people who bought this shoe, that type of thing. But I put the bottom thing is it's still informed by the gap in the literature. If we're saying, gosh, we know a lot about heart disease, but we don't know about this population or this gender, that's who we're going to want to target. So how we collect our data can be verbal interviews or written open-ended surveys or diaries. And I just want to caution you as you do this to make sure when you're writing an IRB to include anything you think you might want to include in your data. So we did a study where we had permission to do this survey. It's a Likert type survey for students. And then we had debriefing that went with it. So we had some wonderful qualitative data from the debriefing, but we did not include that in IRB, so we could not use it. So that was a wasted opportunity that we didn't get to use that data because we did not have, Simon didn't say we did not have permission, nor did the participants consent to that. So when we look at qualitative using low beyond a Wood and Havers level of evidence, it's level 6. So qualitative is level 6. And then if you do a meta synthesis of qualitative, that would take you to level 5. And then again, I'm sorry, I'm going the wrong way. Qualitative in a nutshell, the data are words, and we know the sample is large enough when we reach saturation. So I have Carol Burnett there tugging on her ear saying, you know, we're starting to hear the same thing over and over. So even though they're saying different things, the bottom line is all these people who bought the shoe said it was a great shoe, but the customer service was terrible and they wouldn't use that vendor again. That's a saturation. You're starting to hear the same thing. And the results are reported as themes with qualitative. So instead of just reporting what I just said, you might say the theme was great shoe, terrible customer service. And then you would support it by a couple quotations from our participants, but we wouldn't name names. Then we moved to quantitative. So when you think quantitative, I always say if we had a mascot, it would be the Count from Sesame Street. With quantitative, we are going to measure something. We have to. It's part of this purpose of quantitative. And so when you think quantitative, you got that N, think N equals numbers. We're going to look at some numbers with quantitative. So again, same, the population's global, the sample is our study. And a lot of times what we see with quantitative is a convenience sample, meaning we recruit from who are conveniently available to us. So I always give this example. If I stood outside the library to recruit students to participate in my study, I always say, if you want to look intelligence, as soon as you see the convenience sample, you can take off your glasses and go, I see you used a convenience sample. You may have introduced a bias and limit generalizability, because that's always going to be true. I don't know what's different about the people who are coming into the library. It might just be that they obviously are students who come to campus. They're not virtual. So that might introduce a bias, and it's going to limit how much my research could apply globally from there. The other people we want to think about when we think about who with quantitative are the raters. So students know this instinctively. I teach a class with another faculty, and you know, as a student, either you want Morales to grade you or Morales grades harder, you don't want Morales to grade you. So ideally, our raters would rate the same, and that's called inter-rater reliability. Really should not matter who checks a student off in skills checkoff, for example. The evaluation should be the same. We still have our independent variable. It's the one that's manipulated, that influence the phenomenon of interest or your intervention. So you can just hear the independent influence intervention. So maybe you don't have as much trouble picking out those variables as I did as a student, but that helped me tremendously to think about it that way. And our dependent variable is always that outcome measure. And this is still informed by our theoretical or conceptual framework or the literature. So if my dissertation was on hand hygiene, the patient's hand hygiene, I didn't get to just pick random things to measure, and IRB would never approve that. But I used the health belief model. So based on that, I had to look at perceived barriers, perceived benefits, that type of thing. So that's how it's informed by the literature or your theory. Where for quantitative, we have a good bit of flexibility. It can be online, it can be a survey in the lab, through social media. And now you're seeing more and more data mining, where you might get these mass sets of data to run your own questions on, or with medical research looking at charts. We still have our retrospective, concurrent, and prospective angles to look at for when. And I just want to point out that with quantitative, you can start anticipating what analysis they're going to run. So if it's prospective and they're wanting to predict, they're probably going to run an ANOVA. You're going to start making those connections. And then we have cross-sectional. which is really a concurrent, but I always take a pencil and just snap it into, it's like, we're just looking at this one moment in time, at this moment on today, when you filled out the survey, this is how you felt. That's cross-sectional versus longitudinal, which is ongoing. And so I always say, why do you think most of our studies tend to be cross-sectional? And it's because we got to get done, right? Especially if it's a dissertation, you don't want to be in school forever. And if you look at the Framingham Heart Study, that went on for like 20 years. So it's going to be hard as a researcher to be able to commit that much time. With how for quantitative, it's still going to start with that review of the literature, and we're still looking for that gap. It's still going to be evidence-based. So you might say, we don't know much about goat herders and heart disease in Zimbabwe, but the literature suggests this was effective in this population. So now I want to go do a study to explore that intervention that was effective over here to see, is it effective over there? So it's not like we're never just making things up. How we measure is our tool or instrument. It's very important in quantitative. So reliability is about that consistency. And we already talked about that with the raters. Remember, inter-rater reliability, meaning that we're consistently measuring this phenomenon consistently. And typically you'll look for that Chromebox alpha. And I always just think about a passing score in nursing school. And so like a Chromebox of 80 would be low, but we'd be okay with the 80. And then we have validity. This is saying that we're measuring what we think we're measuring. So if you're looking at stress, but you have a tool that measures anxiety, we already have some validity issues. So we need to start with a concept analysis to say, this is what we want to measure. This is what it is. This is what it's not. And then find a tool that specifically measures that concept. Why? Again, we're just going to look at the purpose of the research and then look at the research question. And the question can be descriptive, comparative, or relationship oriented. It's still informed by that gap in the literature. And we want to think about those implications for practice because, again, nursing is a practice profession. And it's not typically as esoteric as, say, some of the sciences that might be looking at this particular gene and the chemical reaction or that type of thing. Now, this is where it gets a little trickier. So quantitative can be non-experimental or descriptive if you're just doing a survey to get some descriptive data. It can be quasi-experimental, meaning it has some of the elements of an experimental design, but not all. Or it can truly be experimental, meaning it does have randomization, a control, and of course, if it has randomization and control, it has an intervention. Because we randomized them to the control or intervention group. So I said that how we measure things is the tool or the instrument. So how do we select that? When you're looking at, if you're critiquing research, for example, look to see, was it researcher developed? And if it was, again, it should be based on the literature. And they should have performed a content validity index, meaning they should have done some tool development to make sure, typically you get your tool, you create it based on the literature, you send it to a panel of experts and they say, yeah, this question's good, but this one's not. And then based on that, you'll refine the tool. Then you can do a pilot test. And then when you actually use the tool, you can perform factor analysis, much like we do exam reviews. Think about that, how you know a question's solid or not. If it's an established tool, we want to make sure we have permission to use it. And then I can't stress this enough. We have to get permission for any modification. So if you're saying this is an established tool and here's the Chromebox alpha is this, but then you change a question, your results will not be the same because now you've changed the instrument. So we need permission to change an instrument. How we collect the data for quantitative, it can be observation. And then anytime somebody's watching you, you change your behavior. So in my study, I wanted to look at T-zone touching, cough etiquette, and hand hygiene in the lunchroom, I'll say, of a long-term care facility. Well, I couldn't tell people that's what I was exactly watching for. They would catch themselves, right? So I just said I was looking at lunchroom related behaviors. But so this is the Hawthorne effect. Then we have, if the researcher collects it, again, back to that inter-rater reliability. And then our other option is self-report. And our problem with self-report is we are all human and we all overrate our positive and underrate our negative. So if I ask you how many times a week do you eat out, you'll probably shave a little bit off. That's just human nature. And if I ask how many times a week are you working out, typically we round that number up a little bit. So that's always a problem with self-report. So factors to consider, is there, when you're looking at a tool, is there a neutral response? So if there's a 3 on a scale of 1 to 5, you're think about your students who don't want to do the survey anyway. They're just going to take a pencil, and if it's paper, they'll mark straight down the 3. And then are there any items that are reverse coded? So if I'm doing a scale and I say, do you feel safe on campus? And I'm looking at safety. So all but 5 means that you feel safe. But then I throw a question in there that says, how often do you feel the need to call security because you feel unsafe? Now it would be reverse coded. So you just want to always think about that sometimes we throw questions in there that are reverse coded. We always want to think about the participant burden. I know it's election time, so y'all are probably getting all these texts and phone calls like me where they want to ask you a few questions. I did some phone survey jobs back when I was in college to make some money. So I always want to be respectful to the person calling me. But if they tell me it's 5 questions and we're 10 questions in, I tend to hang up or just say, I'm sorry. Or if they tell me it's going to take 3 minutes and then we're at minute 5, again, your person's going to hang up on you. So always look at that, because then we look at attrition and completion. So I always stress, if you leave my study, your data leave with you most of the time. So we want completed responses. And you might think, let me just go back to this a second. I overestimate it thinking, will you do my survey? It shouldn't take you more than 15 minutes. Well, if it only takes 5 and you've told them 15, that's not good either. So you want to have some neutral person take it who has never seen it so that they're not flying through it because they've seen it so many times, and to get a realistic number. You don't want to oversell or undersell how long it's going to take. So here are some things, maybe you don't have trouble remembering this, but I struggled with it. So with specificity, when we look at a test or a tool, I made the P big and bold, but you can remember a specific tool has few false positives. So if you have a positive with that test, you can be pretty sure it is positive because it's very seldom falsely positive. Versus sensitivity, and I made the N big and bold for you, it has few false negatives. So like if you had a negative on that test, you can be pretty sure you don't have that because it's very sensitive. So I think about the D-dimer test, right? If you're an ER nurse like me, the D-dimer, it's very easy to get a positive. It is not very specific, but it is very sensitive. So a negative D-dimer tells you more than a positive. And then I sometimes struggle with remember inductive and deductive reasoning. My son, who has a math degree, kind of always corrects me on this. But I had to think inductive is really kind of from the inside out, meaning generalizability. How much can these results go out? Whereas deductive is more about thinking from the outside in, which is like looking at your theoretical framework and bringing that back down to your study. So when we look at quantitative level of evidence, it will either be non-experimental, descriptive studies is 4, according to this pyramid. Quasi is a level 3, and then randomized control is a level 2. And then if you did a systematic review or meta-analysis of only randomized control trials, that would be a level 1. So quantitative in a nutshell, the data are numbers. We know our sample is large enough when we see a power analysis is done. It's really how we know. The results are reported as numbers, and when we look at statistical significance, which is a P less than 0.05, meaning less than 5 times out of 100 could that difference occur by chance alone. And I just want to touch on this because I mentioned it. If you're a mixed methods person, which I am, If the qualitative strand or phase is done first and then the quantitative, that's exploratory. And I remember that because the L. So qual and exploratory, qual first, exploratory. If quan is first before the qualitative phase, then it's explanatory. And I remember that because the N in quantitative and explanatory. So that's what I had to present, and I'll open it up now if you have any questions, comments, or concerns.
Thank you for this presentation.
Oh, thank you for coming.
Katie, I really appreciated your discussion on clinical practice guidelines. That has, I had a hard time with placing them on the evidence pyramid, which I'm not too fond of the evidence pyramid because it puts qualitative research, it labels it in the same context as quantitative, and I think it's a completely different phenomenon. But I like that you explained why clinical practice guidelines are near the bottom, even though they feel like they're a summary of everything and rigorous like a systematic review, but they're not, you know. So thank you for that.
You're welcome. I did that because I always think when you teach, you struggle with it and then you can present it. So I was struggling myself, Kathy, with why is this so low? And I point out to the students, why is qualitative so low? Is it because it's not valuable? No, it's low because the way on this pyramid you get to the top is having the elements of the experimental process. And we don't have that with qualitative. We don't have an intervention, you know, so it's not that it's less than, it's that we don't even know what to measure. Like we need to find out more about this before we can even start introducing more elements of the scientific process.
Yeah, and that's why I have a problem with it being on the pyramid, because it's not meant to be predictive. And that's what aren't we measuring how predictive the research is in that evidence pyramid?
I think of it as more like,
Yeah.
you know, like if we do the study and we find out that goat herders in Zimbabwe say this is our biggest challenge, now we can use that to inform a more scientific study, right? So we could say, oh, they said eating out's not their problem there. It's, I have no idea because I don't know enough about Zimbabwe, but it's lack of access to care. So then we maybe make sure there's nursery and clinics. So then it can inform, that's how I look at it. But even on that pyramid, another glaring observation that you don't really catch till you're working with students, it doesn't tell you how to rate mixed methods at all. So when a student picks a mixed methods, it's like, wow, what I tend to tell them is typically those pyramid type rating systems sink to the lowest level of whatever. So I think they would probably say it's a 6, but I don't know.
Or does it go to the highest level of the quantitative method that was involved?
The ones I've looked at in the past did the opposite. It would go to the lowest. So even though you might have had a level 2, but then you introduced like in a review and then you brought in a 6, the whole review drops down to 6.
See, I think that it's stronger than if you have a level 2, you did a randomized controlled trial, and you happen to add in some qualitative research that was rigorous. To me, that's stronger than a study that only looks at the numerical value, which is powerful.
I hear you. So the discussion we're having for people that are listening is really about inter-rater reliability, right? So before Kathy and I work together, we would have to have this discussion and say, how are we going to rate it so that we're all rating it the same?
Yeah.
And there's no right or wrong. We just want to make sure we're doing it the same way and on the same page.
Great, thanks.
Yeah, good point. I see there's some chat comments. Let me see what they are. I saw somebody jumped off. I appreciate everybody joining today. And if you have suggestions for future offerings, the Student Engagement Committee could do for you, let me know. I like everybody's comments. I hope it wasn't too fundamental for you. I always say one of the philosophies I have in my teaching philosophy is if I simply can't explain it, I simply don't understand it. So I have to make it pretty simple to make sense for me. Well, if y'all have any questions that you don't, you think of them later or just would like to collaborate or anything, just here's my contact information. Please reach out anytime.